right, guys, welcome back. Today, I kind of jokingly refer to this drug as dopamine's ugly stepsister, but we're going to talk about it. Actually, I think it's a far more effective drug for cardiogenic shock, and that's dobutamine. Okay, again, now the first one thing that all the knuckle dragging hose draggers are going to say is, that's a critical care drug, Scott. Well, sort of kind of is, but we got to know about it. So let's learn about it real quick. Again, so a little bit of a note on this is you're probably going to see this drug on a transfer, and again, we can get these at any time. Just be aware of that, and it must be on a pump. Dobutamine that's one of those kind of like nitroprusside. Truth be known, dopamine it needs to be on a pump. You need to be able to titrate it exactly. Okay, so you got to know what this drug is before you take in the patient. Okay, because there's a lot of things that can go wrong with dobutamine. A lot of things can go wrong. So let's learn about how to avoid those little minefields, because it actually is a very good drug for your shock syndromes that you have. Okay, and it helps correct the imbalances. Again, we use it a lot for congestive heart failure patients, renal failure patients, open heart surgery patients, or if they're even septic, we can use dobutamine to help maintain their blood pressure. It is a catecholamine, guys. It's a pathomimetic. It is an inotropic agent. Ino means squeeze, right? So that's the good thing. It's a beta adrenergic agonist, and it's a synthetic catecholamine. And the key thing is synthetic. Wow. Okay, wait a minute. So this is basically like dopamine. Well, essentially, yeah. So give the patient all the dobutamine. Now, let's not do that. All right. So again, it gives a positive inotropic and dromotropic without really affecting the heart rate. So it gives you a really good squeeze and a really good electrical conduction without speed up picking up. Okay, dopamine's going to pick up your speed. Dobutamine does not, and that's why we really like it. So if you got somebody that's in true cardiogenic shock that's already at a heart rate of 120, 130, this is your drug. Okay, you're going to get very little chronotropic effects with it. It increases the renal and mesenteric blood flow, so you get more flow to the gut, more flow to the kidneys, and that increases your cardiac output. So again, it balances the increasing coronary flow, and again, there's a little bit of vasodilation effects, keyword being little. Again, just a little bit. It actually dilates really what we want it to dilate, which is your kidneys. Okay. So that's why we really do like it. Again, it's just like the dopamine. It's a 1 to 2 minute, and it peaks about 10 minutes. And then once you cut it off, it takes about 15 minutes for it to wear off. So your congestive heart failure patients and the key here is the inotropic support. When I need more squeeze out of the ventricles, okay? If I have left ventricular dysfunction because of maybe a heart attack where the patient's had muscle die, this stuff works great. Again, non-hypovolemic hypotension. Ooh, big words there. Guys, there's got to be fluid in the pipes. If there's not fluid in the pipes, stay away from dobutamine. Truth be known, stay away from dopamine. This is one of those drugs, actually, that I would give a little bit of fluid before I start giving the dobutamine, just to make sure that I've got there. And again, these are not the hemodynamic. Again, and just remember, trying to figure out which one is which, right? Again, make sure you got a little bit of fluid in the pipes before you start, all right? So again, it's just like any other catecholamine. It can cause PVCs. They can go into a tachycardia. It is rare, and usually there's a secondary reason for that. And it can increase the infarct size in a patient with an MI. Remember, you're increasing squeeze. So if they've already had the MI, then it's one thing, but if they're in the middle of the MI, this probably isn't the drug to start using right away. Okay, and it can decrease the peripheral perfusion, and if you, the tissue will become necrotic if it's not inside the vein. Okay, so this is one of those that you really need to make sure that the vein is patent before you start flowing it. Okay, again, a good push. Give them a good, matter of fact, give them that little bit of saline ahead of time, because that way you know that the IV is patent and it's not going to cause no problems. All right. As it is a catecholamine, it can cause hypertension. Okay. If they have pre-existing hypertension, stay They don't have any volume in the pipes, fix it. Uncorrected or uncontrolled tachycardia, probably not the drug to use on these guys, okay? If they have any type of subaortic stenosis, it's going to cause a problem when you do that. So again, you're going to have to look at their history and make sure that they don't have this. And again, if they really react to the sympathomimetics, you probably want to stay away from this drug. All right. So again, it does not like sodium bicarb, and it does not like Lasix. It likes to crystallize all those. Your beta blockers can inhibit the effects of the dobutamine. Okay. So if you're giving them a propranolol drip along with a nitroprusside drip, you might want to be going, why are we doing this? They're kind of fighting each other. Okay. Again, alkaline solutions, they can inactivate dobutamine. And again, if they are oxytoxic or tricyclic antidepressants, they really work. They work well with. They intensify the effects. So you got to really be careful with those guys. This drug actually works really well with dopamine. So if you're kind of getting up on the high end of dopamine, you can add this to the dopamine drip. Or not add it to the dopamine drip, but start the second line with the dobutamine in it, and they work very well in conjunction with each other. Okay, so again, if you've got myocardial ischemia, if you've got signs of ST elevation, it's probably that you want to stay away from this drug. Okay, so you're going to make the infarct bigger because this drug again causes harder squeeze. Okay, they need to get to the cath lab, get opened up, and then they can put them on the dobutamine drip. Again, we got to watch the blood pressure. You should probably have an A line in, but if you don't, again, set that blood pressure cuff for every 2 minutes and go. All right. It can be administered through the Y with dopamine. It can be administered with lidocaine drip, nitroprusside, or potassium. Either one of those that they can be given with. Make sure that the IV is patent and do not administer via IV bolus. We don't just willy-nilly push this drug. It goes in via IV drip. All right, so I can tell you I've not seen the powdered versions. The ones that I usually see is 250 and 250, or I will see or 500 or 250 mLs in 500 D5W. And it's usually your concentration of 1,000 mics per milliliters, and we started at 2 to 20 mics per kilo per minute. Okay, wow, that looks just like dopamine. Hey, look at that. They sound like each other, right? So again, just remember it's a little bit thicker concentration than 1,000 mics per ml. Dopamine is usually 1,600 mics per ml. So again, 1,000 mics per ml, 2 to 20 milliliters a minute. And we base it on the effect that we get. So start at 2, work your way up until you get what you're exactly looking for to bring up the blood pressure. All right? Oh, I'm going the wrong way. All right. Here we go. And then remember, I would be careful because of the pregnancy category C, but I can tell you I very rarely see that on a pregnant patient. And again, we give it via IV infusion only. This is not a push drug. This is the one you give by drip, and it should be on a pump as you give it. Now, the question that you're all burning and asking, well then why don't we just use dobutamine instead of dopamine? Well, that's an easy one. It's the cost. I can tell you right now. Dobutamine, guys, is far more expensive than dopamine is. And for the one patient every 3 years that you might actually get to use this on, where you're not doing a transfer with this patient, the one time every 3 years that you're actually doing that, it's not worth the cost. This stuff usually goes out. I know at Shands Care we had it go out on our trucks all the time. We'd take it back into the pharmacy. They would swap it out with us, and then they would go use it before it expired. But again, for a large service, that might not be it might be on your critical care trucks, might be with your supervisors. Okay, so again, that's dobutamine, the ugly stepsister to dopamine. But again, it has really good uses. I've used it multiple times. And boy, it does work. I will say that. I'll see you guys on the next one.